Good evening. My name's Michael. I am not a believer in boring you to tears for 40 minutes with an overhead projector and a whole bunch of slides and talking to the slides and you quietly doze for an hour. I would much rather that we have an evening where you ask me what you want to know about, and I'll do my best to answer those issues and those questions. Order of play. Let's start with 1, 2, 3, 3A, 4, and 5 as an order of play. Does that look reasonable to you guys? Okay. All right, so why would you go to that particular place? Well, clearly it's because I'm wonderful.
I said it was different.
You want to go to a place that's easy to get to. So you want to go to a place that's convenient, because you're building a relationship with the radiotherapy department, with the radiation oncologist, that hopefully you're going to have for many, many years. And so to go from here to Wollongong for your checkups is just inappropriate. And for someone from Wollongong to come to Sydney for their checkups is inappropriate. You want to go somewhere that's convenient and local. So that's one thing. Second thing, you want to go to someone who you feel comfortable with. So you really do need to be able to have a conversation with them, and you really do need to be able to talk about the nuts and bolts of your bowel habit, of your bladder habit, of your sex life. And you've got to feel comfortable doing that. And if you've got someone who's sitting opposite you, sitting somewhat po-faced, and you don't click with them, then, maybe you want to give a bit of thought about that. Now, yes, it takes a while to warm up to an individual, and you may not be that certain the first time around, but there's no particular reason why you can't go and at least have a couple of opinions and see the pros and cons. The clinician, the person who's doing the talking, should be also doing the listening. And if you don't feel that they're listening to you, if you don't feel that they're actually addressing your concerns, then again, perhaps it's worth giving them a thought about it. I'm a believer in, if you go in with another person, you've got 4 ears, 2 sets of ears to absorb the information. And I think that if the clinician isn't actually talking to the other person and totally focused on you, then maybe there's something wrong with that setup. So the clinician should be able to deal with whoever's in the room and accept that you've chosen that other person to come into the room with you to assist you with your decision-making process, to assist you with the information gathering. So you've really got to feel totally comfortable with that. It's the patient who chooses who comes into the room with them. It's not the clinician. It's not my job to say, no, I'm only taking one other person in. If you want to bring a tribe of people in with you, that's entirely up to you. It's your right and your prerogative to do so. And it's my job to handle that. And so that, you're going to get an idea, an understanding of the person that you're talking to on that score. The equipment is a part of the process. You would like some equipment that is probably within the last 5 years. Linear accelerators have a working life of around 5 to 7 years. So a machine that's 6 years old is probably perfectly adequate, is probably absolutely fine. We've just replaced our oldest linear accelerator, and that was about 6 years old at the time of replacing it. And it was working absolutely fine. Excuse me. But if you've got a machine that's 10 years old, if they're talking about dealing with a machine that's 10 years old, then you probably find some better bells and whistles on a machine that's a little bit younger than that. They do turn over. The companies that sell these machines to us try and put something different onto the machine to make it new and wonderful every couple of years. But certainly the one that's 2 years old or 2 years new is not appreciably different from the older one, and the one that's 4 years new, it's still not appreciably different from the older one. Once it's sort of 6 or 8 years new, then you do start to see some differences. So you want a machine that's reasonably fresh. The staff who actually deliver the radiotherapy treatment, you're not going to meet them until you're actually in the process of meeting them. But I guess if you're comfortable with the front desk staff, the chances are that you'll be comfortable with the other people that are there. If you're comfortable, if you feel that you've got rapport with those people who are, answering the phones and what have you, then the chances are that attitude is going to flow through. So those are all different aspects of it. In terms of the radiation oncologist, you want we're all of us trained to a standard. We're all of us trained to be able to deliver the radiotherapy. So I'm not sure that you're going to get a lot of clinical difference in terms of what's delivered. So that's a fairly difficult choice. So it then becomes a question of personal reference. Is the surgeon comfortable? It's nice to work with a team. So if you feel that the surgeon works hand in hand with one particular rad-onc, well, the chances are that they've got a good relationship, and that there's an expectation of what will happen. So those are all things I think that you can probably look at on that. Has that answered your question? Is there any other questions relating to that before I move on? Is what I've said sound reasonable? Cost, I suppose, is an issue. The public is a different price structure to the private system, but cost is one of those things that if you've got an issue with the cost, discuss it with the front desk. For me, I work in the private system. That means that I can charge pretty well anything from Medicare only through, but it depends very much on the individual situation and circumstance. If I've got someone who really is on their uppers, then I'm going to do my best to help them. But at the same time, it's not nice to be abusing that privilege either. So it's one of those things. So it does depend a little bit on what's going on and what you're doing. For instance, with seeds or with the brachytherapy, I have to charge a fee for that because there's a lot to it and there's a lot of staff and there's a lot of effort that goes with that. But it all depends a little bit on the techniques and what you're dealing with. Okay. So then, staging. So how do you know what to treat? How do you know where to treat? Why are we looking to treat? And so it's all a question of trying to work out what the playing field is to work out what sport you're going to play. If you've got someone who comes, if I've got someone who comes to me with a prostate cancer, I'm looking to see the extent of their disease, because if I can understand the extent of their disease, then I can talk about what's appropriate treatment for them. What's appropriate for one person may not be appropriate for another. Someone who's come with metastatic disease, with a spot in a bone, for instance, well, then they potentially have a very different treatment pathway to someone who's got a very early, very small focus of disease in their prostate and only in their prostate. And so what we're trying to do with staging is to try and establish just exactly where the disease is, so that we're going to get an appropriate treatment pathway, an appropriate treatment plan for them to exactly assess where the disease is, so we can put the radiotherapy fields on. Surgery is very much going in with a sharp implement and trying to cut out a particular spot. And the idea that the surgeons have is that they're going to remove the prostate and maybe sample one or two of the lymph nodes, but they're not going to do too much else. The advantage of surgery is that you get something to look at under the microscope, and you can see what you've got, and you get an idea, a black and white idea of what there was, rather than an estimation, an assessment, an approximation of what there is. But whilst it's nice to see that, it doesn't actually guarantee that you fix the problem. And the belief that if in doubt, get it out, doesn't actually hold true. And surgeons very much rely on the very human attitude that we have of, I don't want it there, I would like it gone, I would like it gone now, I'll have the operation, thank you very much. And that doesn't necessarily achieve anything, but what it does achieve is the individual peace of mind that I've had the operation, I can get back to my normal living. And then the pathology report comes back and it says that no, in actual fact, there's this and there's that and there's the next thing. And all of a sudden you realize that that didn't actually solve the problem, solve the dilemma that you thought it was going to do. Long-term results for surgery are not that different to the long-term results for radiotherapy. It depends a little bit on whether you've got low-grade, low risk, intermediate risk, or high risk as to which of the three options. If you've got a low-risk prostate cancer, then surgery does marginally better than radiotherapy. If you've got an intermediate risk prostate cancer, then surgery and radiotherapy have very, very similar, external beam radiotherapy have very, very similar control rates in the long term. And if you've got a high-risk prostate cancer, then surgery does worse than radiotherapy. So it really does depend a little bit on what you're dealing with as to what's an appropriate treatment option, and staging helps us with that information. With radiotherapy, imaging is the be-all and end-all for us, because if we can see a volume, if we can see an area of where to place a field, of how to shape our field, then with radiotherapy we can place the radiotherapy volume around that area to make sure that we're getting an adequate dose into that area. If we can see what we're doing, we can also try and shape our radiotherapy fields to miss those structures that are sensitive to the radiation, and try and then reduce the side effects of the radiotherapy. In the old days, when I was a registrar, my boss told me that as far as a prostate cancer field was concerned, you put on a 9 by 9 by 9 centimeter box into the pelvis, and you treated everything that was within that cube. And that was how it was done. 4 fields, one from the left, one from the right, one from the front, one from behind, and you treated this area. And everything in the middle got the 60 to 66 gray that could be safely delivered. And of course there were side effects, and that was why 60 or 66 gray was considered the safe dose, because higher than that, and the bladder and the rectum would start to get significant side effects. And then we started to shape the radiotherapy fields, and we started to trim the corners on that cube. And we found that by doing that, you could raise the dose from 66 to 70 gray. And we started to do a bit more shaping, and we've raised the dose to 74, and now we're talking about putting 80 gray external beam radiotherapy onto the prostate. And so we really need the imaging. We need to see with a good CT scan exactly where the bladder is sitting, where the rectum is sitting, and where the prostate is sitting, or the prostate bed if you've had the prostate removed beforehand. But not only that, we also want to see where the tumor is. And CT scan and an MRI scan will show you the anatomy. A CT scan will show you where muscle is, a CT scan will show you where bone is, it will show you where the structures are, but it won't tell you the content of the structures. It won't tell you if those structures have prostate cancer in them or not. And so a CT scan will give you quite a lot of information, and it's certainly very useful for me for planning, for working out my radiotherapy fields, because that gives me the shape, that gives me the external contours, it gives me the internal contours. It shows me where how to put my radiotherapy field on. But it doesn't particularly show me that this is an area that's a problem area, or this is an area that's a problem area. Now, an MRI is very, very good for anatomy, and it gives me a little bit of information about the content, about what's happening inside a place. It'll tell me a little bit about whether that lymph node is a problem lymph node or not, slightly more than I'll get off a CT scan. But the PET scans are related to the bone scans. They look at the metabolic activity. They look at the busyness of the structure, of the volume that's there. And so a PET scan and a bone scan is an injection in the arm, and you lie on the machine, and it will take an image of you that shows where it's busy, where this chemical has been taken up in concentration that isn't normal. And a bone scan is taken up only in the bones. A PET scan is taken up in soft tissue, and it's great for the brain, it's great for the heart. Will give you a little bit of information about what's going on in the bones, but it doesn't give you necessarily a great deal of information about the lymph glands. But the newer injectable agents give you much more information about what's happening with prostate cancer. Now, in actual fact, choline is now old-fashioned and out of date. It was a hot topic for a couple of years, but with the introduction of PSMA is more accurate than the choline, or appears to be more accurate than the choline scans, and so we're not doing choline scans anymore. We're just using the PSMA scans. So it's still a PET scan, it's just a different chemical. It's still injected in your arm, you still wait a period of time, lie on the couch, and then they meld the image that they take with a CT scan so that you can see where the structures are, and you can also see where the busy structures are, which can be a lymph gland, or it can be the prostate, or on the prostate bed, or in the bone, or wherever. Medicare hasn't recognized it yet. And because Medicare hasn't recognized it yet, it's fully out of pocket. There's no Medicare rebate at this point in time. And it's somewhere between $600 and $700 out of pocket for a scan. So they're very useful. And as far as I'm concerned, it's extremely helpful in talking about the volumes and what we should be and what we shouldn't be treating. When you've got someone who's had their prostate cancer treated and their PSA starts to rise again, we used to have to wait until the PSA was up around 10 before you could start going looking. You know, if you were feeling brave and courageous, you might go over the PSA of 5 and hope that the CT scan was going to show something and hope that the bone scan was going to show something. But more often than not, you were a bit disappointed by the result, that it came back showing nothing. Well, the PSMA scan is certainly valid and useful over 1.0, and in some situations it's valid and useful with a PSA of 0.2. So we can look with the PSMA scan at a much lower reading. And being able to look with the PSMA scan at a much lower reading, we have a better chance of identifying when there's a volume, when there's a problem, or where there's a volume and where there's the problem. And by doing that, identify at an earlier point, and possibly then look at focal treatment, local treatment onto that point. And so this concept of early identification of the malignancy is something that is very new and has appeared in the last 3 years or so. It appeared in the last 3 years or so, 3 years ago. People were a little bit, not sure about that. And it's slowly becoming more mainstream. Depends on who you go and who you talk to. You're still likely to meet people who are old school and say, no, it's a waste of time, it's a waste of money, you're not going to achieve anything useful out of that. But slowly there's a groundswell that's happening where people are recognizing that in actual fact there is a situation where identifying low volume recurrent disease is potentially very useful, and is potentially in a situation where you can have a second bite at the cherry, you can have a second bite at the apple. You have a second opportunity to try and re-establish long-term control without shrugging your shoulders, giving up and moving on to the hormone treatment. So the introduction of particularly PSMA, but to a lesser extent MRI, has been very helpful for us in identifying areas that are potentially a problem. So,
there's been a trial. Have there been any published results from the trial?
No, there are several studies underway at the moment in different places. No, that's still accruing and still working through. But what data there is at this point in time is still relatively limited, and it's still a little bit textured. It's still a little bit coloured by what's the agenda of the person who's doing the trial. It's only small numbers, and it's exactly who was funding the trial and what are you trying to get out of it. So until we start to get larger numbers from the sort of the major centres like Toronto or MD Anderson and places like that, out of the UK even, you know, there's always going to be an argument for poo-pooing this sort of advanced edge of treatment. And I can understand that, but I know if it was my prostate, I know that if I was in that situation, I'd be looking for that. I'd be looking to try and get that second chance of long-term control. And that certainly seems to be useful. Is it useful all the time? We don't know. One of the problems that we've got with metastases is if it's got out to one place, does that mean that it's got out to 100 places? And that's where this concept of oligo metastases comes in. Oligo means, depends on who you're talking to in definitions. Oligo means 1 or 2 or less than 3, and in some situations and scenarios less than 5 different spots. With prostate cancer, we're talking about 1 or 2 metastases. And the idea is that there is a change in the makeup of the cancer cell and the makeup of the ability of the cancer to spread in different places. And if you can get it early enough, you have the potential, in theory, to control the disease and stop it from then migrating onto other places. So that the clone that has shown the ability to metastasize, you've caught it quick enough that you can stop it from moving on to these other places. And we don't know whether that's whether that's reality or not. Yes?
So what defines early enough or quick enough?
Identifying 1 or 2 lesions, and only 1 or 2 lesions. And so that's where being able to identify with a relatively low PSA is of use. With people who are post-prostatectomy, people whose PSAs are rising after they've had their surgery, and then they're watching their PSA and it starts to rise again. With external beam radiotherapy, we know that if you wait until your PSA is more than 2, that there's not a lot of benefit out of using radiotherapy into the pelvis because the chances are it's already moved elsewhere. If the PSA is less than 1, then you have a better chance of trying to do something and re-establishing that control. But your best opportunity of establishing and getting that second opportunity of getting control by the addition of radiotherapy after a prostatectomy is when the PSA is less than 1, 0.5 or even 0.2. So the smaller the volume, the better the chance you have of being able to re-establish control of that disease. One of the things about that is that it's also a question of, has the cancer moved away? Is it still focally around the prostate bed, or is it in the adjacent lymphatics? Well, same story with the oligometastatic story. If it's only gone into 1 place or 2 places, it's entirely possible that that's the first point of disease spread. And if you can catch that one before it then starts to act as the nidus of disease, then maybe you can do something about changing the natural history of that malignancy, of that person's malignancy. There was an interesting study looking at metastases in mouse brain, and they injected into the vein in the back of the mouse brain tumor cells, and then they dissected the brains, and they found that if you injected in several hundred tumor cells, that you could identify these in the mouse brain, that they'd gone in there and they'd lodged there. But then, as they delayed the killing of the mouse and looking at the brain, they found that a lot of those metastases, a lot of those cancerous cells, were cleaned away by the body. And it was only a few of them that then started to grow up and become metastatic lesions that survived in that tissue. And so it's possible that even though you've got this sort of spray of metastases that have occurred, it's possible that the body can clear away most of them, and it's only 1 or 2 that are left there that then start the process and moving on. So there's a lot we don't know still. There's a lot we don't understand still. But there is an argument that maybe treating this oligometastatic burden is going to be something useful. Now, the other aspect about dealing with those is this new technique, is this new option that we have of how we deliver the radiotherapy. And stereotactic body radiotherapy is a way of putting a very big dose of radiation into a very small volume. And so if you can see that you've only got this one lymph node that's got the tumor in it, then maybe you can put a a big dose of radiation in a short number of fractions, as a, for instance, 30 gray in 4 fractions or something like that, then that's going to knock that tumor out. But because you're putting in such a small volume, you're potentially not going to be causing too much of a side effect to anything that's in the neighborhood. And so we're sort of trying to tie the oligometastatic story in with the stereotactic body radiotherapy process. How much of that is gimmick? How much of that is real? I think it's real. I don't think it's gimmick. But it certainly does mean you've got to choose who's appropriate for that treatment, and you've got to look at, make sure that they're fully staged, fully worked up, and you're confident that there really is, that these are the only 2 spots that are present before you go looking at treating with that. So when do you time that treatment in? Well, the reason for doing the PSMA scan is to identify the extent of disease, and in particular is to try and identify why the PSA is rising in a scenario you don't expect it to be rising. So it's more relevant really for someone who's already had one go at treatment, be it a prostatectomy or be it a radical course of radiotherapy. And then all of a sudden, everything should be fine, the PSA should be down, everything should be roses, and then all of a sudden the PSA starts to come back up again. So why is that happening? That's when the PSMA scan is at its most useful, because it's going to show you where this focus, or is a much higher chance of identifying where this focus of disease is. But the object of the PSMA scan really is to identify whether you've got a couple of spots or whether you've got more than a couple of spots, so that you can then say, well, yes, there is another step, there is an alternative, namely the focal radiation treatment, to try and re-establish that disease control. If the PSMA scan comes back and says there's 5 or 6 spots, then you still have to go back to the hormone treatment that you were talking about, that you had lined up in the first place. So that's where the PSMA scan is a good differentiator. If you're on hormones already, the chances are that the PSMA is not going to be overly useful, because the decision's already been made that there's a wide spread of disease already, and you're trying to look at exactly where this is. If you've got a rising PSA whilst you're on hormones, then you've got disease that is not sensitive to the hormones in that situation, and that being the case, no, it's going to show those spots anyway. What it may not show is the suppressed spots that are also present. So it depends on, again, exactly why you're doing it and what your intent is. So SBRT is relatively modern. There's not all of the linear accelerators in the country are capable of doing that. Probably one LINAC in most centers is equipped to be able to deliver focal radiotherapy to the small volumes, to the accurate volumes. But it does mean that you can treat a bone, for instance, like a bone in the spine, and treat that very quickly to a much higher dose than you can with conventional radiotherapy, and get a better opportunity at controlling it, and at the same time keeping the dose away from one of your organs at risk. So, for instance, with SBRT, if I've got I'm a hopeless artist, so please forgive me. If I've got a vertebral body that's shaped something like that, and the spinal cord is sitting in here, then we don't really want to put the radiation onto the spinal cord, because if you have to do that and do it repeatedly, you run the risk of damaging the spinal cord and either causing pain or causing paralysis of that particular, or below that particular level or region. So if we've got a metastasis that's sitting here like this, the old-fashioned way of dealing with that was to just put a single shot of radiation from the back. So it's called a direct posterior field. And you'd kind of hope that you get most of that dose. You get most of that dose to cover the target in question. I don't think that's a particularly effective way of doing it, and conventional radiotherapy for me now involves putting in several radiotherapy fields so that conventional radiotherapy would cover that kind of a volume. But you can see that I've still got spinal cord in that volume. With SBRT, that's the sort of volume that we get with SBRT. And so I can trim off and I can avoid dose on the spinal cord in the process. So it is, it's a very elegant way of putting radiotherapy into a volume. SBRT? On vertebrae, about 18 months. It's very useful if you've got one vertebra. It's not so useful if you've got half a dozen. So again, it's relevant for the person who's got low volume disease. Okay, so I think we've talked about those. Are you comfortable that we've addressed those? Nothing in life is perfect, so you can get negative PSMAs. You can also get false positives. I've seen a couple of people get nodules in their thyroid that are completely unrelated to their prostate show up on a PSMA scan. So they're not perfect, but if your PSA was more than 0.5 when you had that test, then the chances are that's a very good thing. It's a different thing to a PSA. It's a different thing. It's a totally different thing. PSA is an antigen in your blood, so it's a blood test. It measures one of the chemicals that is secreted by the prostate cells, and those prostate cells produce that normally. The PSA is a normal part of the male sexual function. And so all you're doing is you're measuring what's floating around in the blood that shouldn't be floating around in the blood. PSMA is a chemical that looks at the surface of the cell. So it's a completely different thing. It's just prostate-specific membrane antigen as opposed to prostate-specific antigen. It's different. It's different. So it's not the same.
Is that scan for a full body?
Yes. Yep. Okay. So I'll briefly talk about space-OR. One of the problems that we have with radiotherapy is that if that's your prostate, we have a little structure here called the rectum, and we have another little structure here called the bladder. And so what we're trying to do is we're trying to put radiotherapy into this volume and not put dose onto either the bladder or the rectum. And for that matter, also try and keep the dose of radiation down on the urethra in the process. And you can see from that when all said and done, that's almost an impossible task. So what we're trying to do with the imaging that we've got is get a better idea of exactly where these structures are so that we can minimize the volume of the bladder, we can minimize the volume of the rectum that's in the radiotherapy fields. One of the things is that the space between the rectum and the prostate is about that much. So they really do butt up against each other, excuse the pun. That's why part of the examination of a person with prostate cancer involves a rectal examination, because you can feel what the prostate feels like through the thinness of the wall of the rectum. They're that close to each other. So when it comes to putting radiotherapy into there, you can run into all sorts of problems with side effects. And so people have always said, well, I wonder if there's something we can put in that can separate the two and separate the two out. And there is now. And there's a product, this product space-OR, which we inject in, and it goes into this space in here. And you can end up with, ideally, the prostate on one side of it and the rectum on the other side of it, and you've now got a distance separating the two of them. So that when we come to put the radiotherapy on, if we're putting radiotherapy on, we're doing that. And there's less rectum that's in the radiotherapy field. So spacer is injected up the fork between the legs in much the same way, and I do it at the same time as I'm putting the gold seeds, I'm putting the fiducial markers into the prostate. It's a gel. It's very like araldite. It is. You mix the two together. You've got them sitting in 2 syringes with a Y-shaped connector between the two. You find your spot. You put some saline into that spot to make sure that you're comfortable that it is the spot. You're doing this all with an ultrasound in the bottom to show that you can see what you're doing. And as soon as you've got the needle tip in the right place, you push the plungers and you push these two substances together. And the idea is that they meet in the middle, and at that point in there, they then set into this gel. And if you get it wrong, if your timing is out, if you take your pressure off the plunger for about half a second, it sets in the needle. So it's a bit of a challenge, but it does mean when you've got it in the right place and everything's working very nicely, you can get that gel into that space there. Now, the downside to it is that it's difficult to separate what's prostate and what's spacer on the CT scan, and so you need to use an MRI to be able to separate what the structures are when you come to do your planning. But you can see. Now, you had a question? So if you're doing the radiotherapy after you've, in the post-prostatectomy scenario, there's no role for spacer, because in that situation, you're not looking to treat the prostate, you're looking to treat where the prostate was, and you need to then treat that front portion of the rectum. So it doesn't save those people, no, but when someone's got an intact prostate, it's quite useful. So it's good with the external beam radiotherapy, and it's also good with the seeds patients. No, it melts, it dissolves. It takes about 6 to 8 months to dissolve, and the body clears it away. So it's quite useful. And the timing works very nicely for seeds, because the bulk of the dose from the radiation from seeds gets given through in that first 6 months. So it times very nicely with the seeds. So that's spacer. Downside to spacer is the cost. It's about $2,000. But if you are covered with a health fund, and it's done as an hospital inpatient, then it's covered as your health fund will pay for it. So it's not much use as an outpatient because you're out of pocket. So the idea is to be brought in as a day patient, have the procedure done that way, and then get the health fund to pay for it. Anesthetic, at the moment I'm using a general anesthetic. The person is fully asleep. The men are lying on their back with their legs up in the stirrups in that glory B position. Whilst they're asleep, the ultrasound goes into the bottom so that I can see where and how I'm placing the needle to put it into the right place. We're talking about trying to do it under local anesthetic. There are places that do it under local anesthetic and say it's absolutely fine. I have yet to see that actually happen. I'm prepared to believe it works, and I'm certainly looking to see if I can do it under local, because it then avoids the need for an anesthetic for you, which is potentially useful. So that's spacer. So it stands for space OAR, organs at risk. Okay, so then that brings us on to the big topic of the evening, the elephant in the room, as it were, the side effects of radiotherapy. There was a fellow called Eli Gladstein who was the emeritus professor of radiotherapy in the States. And some years ago, perhaps about 20 years ago now, he retired, and in his farewell address to the American College, he likened radiotherapy to herpes, the gift that keeps on giving. And that pretty much sums up radiotherapy. The radiotherapy effects don't disappear overnight. They stay, and they can keep acting and keep doing things for some years afterwards. So there are several aspects to that. First of all, if you have side effects at the time of your radiotherapy, it's possible that those side effects can persist and can hang around. If you don't have side effects at the time of having the radiotherapy, it's less likely that you're going to have problems in the longer term. In terms of the duration of the treatment, we believe at this point in time, or we have believed up to this point, that giving the dose of radiation over a period of several weeks reduces the side effects on the bowel and the bladder. But now we're getting down to this point where we're using smaller fields, and we're starting to look at giving bigger doses per fraction because there's less normal tissue in the way. And there's hope that that's going to reduce the side effect profile in the longer term. Now, I'm not completely convinced that's true because there's a lot of other things that have got to be sorted out. But that is one place, one direction that people are going looking in terms of the radical radiotherapy treatment process. One of the advantages of the radical treatment process is that it's not an 8-week course of external beam radiotherapy. It's only a 7 or a 6-week or even a 5-week course of radiotherapy. So there's definitely an advantage to the individuals having the treatment. But hopefully that also will result in fewer long-term side effects. One of the other things about long-term side effects is that if people come along and they say that they've got water problems, that have difficulty holding their water, for instance, 5 years after their treatment or 6 years after their treatment, one of the things I'm going to ask them is just exactly how well are you doing your pelvic floor muscle exercises? Because the radiotherapy does impact on the muscles of the pelvis, on those lower muscles of the pelvis, because that's where the pelvic floor muscles are. And unless you've been good at doing pelvic floor muscle exercises through those years, then the radiation is going to cause some fibrosis, that's some scarring, and some thinning of those pelvic floor muscles. And this is probably something I've only learned in the last 5 or 6 years myself. And it means then that really I strongly encourage all of you to do your pelvic floor muscle exercises from the point of your diagnosis of prostate cancer going forwards, and to keep doing them for the rest of your life. It's not that difficult to do them. If I may, I'll say to you what I tell every single patient. Imagine you're in a room and you're in mixed company or polite company and you have a fart building up. You're going to squeeze that fart in. You're not going to let rip, are you? Majority of cases, no. Majority of cases, you're quietly going to subtly and surreptitiously squeeze the muscles in between your legs and squeeze that fart back inside. Now, you're all sitting there in your chairs. You can all quietly, surreptitiously and subtly squeeze those muscles as you're sitting there. And if you're not moving, then the chances are that you're doing the right muscles. But you'd be surprised at the number of men who actually need to be taught that. As you're squeezing that muscle, you should be able to feel your scrotum or the back of your penis twitch. That forward component, that forward part of your pelvic floor is what you're trying to build and keep strong. And it's that forward twitch, that twitch in your scrotum or on the back of your dick, that's what you're trying to do as your pelvic floor muscle exercise. And you can do that brushing your teeth. You can do it emptying or loading the dishwasher. You can do it at the start of every TV program when you're sitting in a chair. You can do it at the red traffic lights. There are multiple points through the day that you can do this that doesn't interfere with everything else that you're doing. You don't need to go off into a darkened room and sit there for 20 minutes, building up the courage to do it. It can be done. And it's something that we should all be doing. And yes, it's secret women's business. All the women are nodding their heads. And it's something that men should be doing too, particularly if you have had some rotten doctor guddling around with your prostate. So get going on it. There's no shame in talking about it. There's no problem in doing them. But it's something, regardless of whether it's surgery or whether it's radiotherapy or both, it's something you need to be doing. Not so much for now, but for 3 years and 5 years and 10 years' time. If you come to me after 5 years and you've not been doing your pelvic floor muscle exercises, I'm going to tell you to start doing them. But the challenge then is that you've got 5 years of catch-up. In terms of timing, these things can come back. They can come back years later. They can come back some considerable time downstream. But in all likelihood, for those people that it has come back, they might well have had, or probably had, more side effects at the time of their radiotherapy. It tends not to be as severe for those people that sailed through their radiotherapy and had very little in the acute phase of their treatment. So, in terms of timing, when you've had your radiotherapy, you've had side effects, then there's an expectation that they're going to settle down again afterwards. And that sort of time frame, if that's the end of the radiotherapy and that's the start of the radiotherapy, then the side effects are going to build up and they're going to reach their peak just before the end of the treatment, but then they're going to persist for a little while and then start to fade down again. So if we call that 8 weeks, then that point there should be 3 months. By 3 months afterwards, I would expect you to be pretty close back to where you were to begin with. But if you did have side effects there, then at some point later you can have some side effects recur. And they can come back. And it's not that they will come back, that they can come back. The radiation's gone. The radiation travels straight through. That's how long it's in your system. The effects of the radiation, the effects of the radiation can hang around for a while, like the rest of your life. You're sitting there 13 years later, so you know. So I've done something.
Thank you.
But I wouldn't expect there to be significant problems at this point in time. I would not expect that. The majority of the side effects, if they're going to come back, are going to come back probably within the first 3 or 4 years. So the question was, being prone to skin cancers, are you more as sensitive on the inside as you are on the outside? No. You're certainly potentially... no, they're quite different. The UV action on your skin, you're not going to be getting UV on the inside, and so that's going to be a different mechanism altogether. Everybody gets skin cancers, unfortunately, some people more than others. Were you a redhead? No?
He grew up in the tropics.
Right, okay, so full-on exposure, yeah, that's going to do it. And exposure from an early age as well. So that's the reason there. Yeah, absolutely. Absolutely. You're immortal then. But the action, no, were you a smoker? Okay, there's your bladder cancer. So that's just, you know, part and parcel of that one. The chemicals are excreted by the kidneys, concentrated through the kidneys and concentrated and sit in the bladder. And so the lining of the bladder gets exposed to all those carcinogens from the smoking. But the majority of that second line of side effects will appear within that first 5 years or so. When they do reappear in that situation, or if they reappear, when they reappear, they're much harder to deal with because you're dealing with the late effects at that point in time. And you're dealing particularly with something called fibrosis, which is that scarring. And the fibrosis is predominantly on the blood vessels. And if you're getting a poor blood supply into a particular region, then you start to struggle with that particular organ, that particular structure, be it bladder, be it rectum, being able to cope with the poorer blood supply. Same as someone who's got bad veins in their, or bad arteries in their legs, getting claudication when they're walking. Well, if you've got a poor blood supply to your rectum or to your pelvis. No. Yeah. So the timing relates a little bit to whether it's that first or the second wave that we're talking about there. What have I written there? Duration. How long is it going to last? In the short term, you expect it to settle down within 3 months. In the longer term, it can take months or years to settle down. It can be permanent. Fortunately, those longer term side effects are less common. But when they do occur, they're pretty miserable. There are different treatments for them. You can use steroids. You can use hyperbaric oxygen is an option for them as well, particularly with bleeding, but sometimes with pain. And non-steroidal anti-inflammatories can be of benefit as well. So there's different things that you can try in that setting, in that situation. With the bowel, the side effects that you get on the bowel are bleeding from the backside, or a stricture, a stenosing of the rectum. And that's particularly when the whole of the rectum gets a dose of radiation as part of treating a larger area. But if you've just got a portion of the rectum getting a dose, then there's more of the rectum that didn't get that bigger dose, and so there's less chance of getting that stenosis, that scarring, that narrowing in that area. And that's where things like the spacer is quite useful to help keep the full volume of the rectum out of the radiotherapy fields. Then, along with the stenosing, you can get something called tenesmus, which is pain or discomfort, so certainly that can be uncomfortable, if not intolerable. Non-steroidal anti-inflammatories usually or often will help get rid of or relieve that pain. Likelihood of that happening is small, probably of the order of 3 to 5%. So that still means, you know, 1 person in 30, 1 person in 20. But it does mean the other side of that, 19 people don't have that problem, or 29 people don't have that problem. So it can happen, but it's thank God not a common problem. On the bladder, bladder is a couple of things. Bladder is not just the bladder, but it's also the urethra. Because you've got a couple of aspects there. You've got the risk of stenosis here, the risk of a narrowing down there, which is called a stricture, or you've got the risk of the cystitis and the irritation on the bladder up there. Prostate inflammation of the urethra within the prostate, generally speaking, isn't such a problem because it doesn't have much in the way of nerve endings. It isn't the narrowest point, but it can cause problems. You can get stones sometimes appear within the prostate. They can occur, but the stricture or the cystitis are the uncomfortable things. And they're going to do things that you'd expect. They're going to give you the frequency, they're going to give you the pain and discomfort, the urgency, and with a stricture they give you the slow, thin stream that just means that you stand there forever waiting for something to happen. What can you do about it? Again, there are things that can be done, but it is difficult for someone who's got those as a chronic long-term problem. Again, fortunately, the likelihood of it happening is small, but when it does happen, it is a significant issue and a significant discomfort. You can do dilatations, you can stretch that up. You can get to the point where the individual can be taught how to catheterize themselves. Not so much that they've got to walk around with a catheter, but that they can keep that stricture open and patent by popping the catheter in once a week or something like that, in and out, just to keep it stretched open. That's certainly one of the ways around that one. Surgical reconstruction is very difficult. It's an area where the blood supply has been compromised, it has got scarring, and so surgeons are very loath to go in there and try and help correct that. They can often make the situation worse when they do try. Cystitis, the inflammation and irritation, you may need to use sodium, sorry? It's just exactly. So I was sodium bicarbonate, which is commercially Ural or Citrovescent, but they keep the acid out of the urine to help reduce the inflammation and the irritation that's in there. Other than that, hyperbaric oxygen again might be helpful, particularly if there's bleeding in that situation, in that setting. The other thing is painkillers, if you need to use painkillers. So non-steroidal anti-inflammatories, often a course of naproxen for a couple of months might actually be enough to break the cycle to help it settle down again. Other side effect that I haven't talked about is second malignancy, bladder. The likelihood of radiation causing a cancer is very, very small. It's one of the things that surgeons love to talk about. Oh yes, but that radiotherapy, that can cause cancer. Well, yes, they are correct, it can, but the likelihood of radiation causing cancer is very low. the risk of getting a cancer from radiotherapy, you're talking about something that's anywhere from 7 to 25 years downstream. So it's not something that's going to happen this year or next year. You're talking about something that's going to happen within the area of the radiation. So radiotherapy to your prostate is not going to cause a lung cancer. The likelihood is somewhere, depending on the literature, and there's plenty of literature about it, varies from somewhere about 1 in 500 to, 1 in 400 to 1 in 5,000. But talking to the radiobiologists, the likelihood is about, the belief is it's about 1 in 1,000 as a lifetime risk that the radiation can cause a cancer. Now, that 1 in 1,000 risk is also about the same size risk as the anaesthetist causing a heart attack at the time of your surgery. But the surgeons don't really mention that one all that much. And it's also something that happens at the time of surgery and not 5 and 20 years later.
Even if you don't have it, you die anyway.
That's right.
You're in a no-win situation.
You are. The point is, the risk is very, very small.
Yes.
And people tend to beat it up a bit. It doesn't need to be anything to worry about. But everybody's individual and everyone's entitled to their own concerns and fears. And everyone deals with them as they wish and as they will.
The tomo radiotherapy treatment.
Right.
How successful, how effective is that? You read a lot in the literature that says it's the greatest invention since sliced bread, but how good is it?
It's the same as any other linear accelerator. It's just a different way of delivering the radiation. What the tomotherapy machine did was that it woke up the people who were making linear accelerators to work out and improve their radiotherapy delivery. So what tomotherapy does is it treats, there's the person lying on the treatment couch, and the tomotherapy machine treats in a spiral down the length of the radiotherapy field. So if you're treating someone from here to here, the tomotherapy machine is terrific because you can treat that in a single field. But if you're treating someone who's just got one area here, then you don't need that spiral treatment. You need circular treatment around that point. And so what it woke up the linear accelerator people to do was to change their radiotherapy fields from giving it in 4 or 5 different directions to giving it as an arc treatment. And so what we've got with the linear accelerators is something called VMAT, or rapid arc. And that's basically where, instead of being treated from here and then the machine moving to here and treating and moving to here and treating and moving to here and treating, we now have a machine that's giving 359 fields that's treating as it's going around. And so the tomotherapy machine was very, very conducive to actually making the linear accelerator people wake up to the fact that they were missing out on an improvement that they hadn't had. For treating small volumes, the tomotherapy machine is no different to modern LINAC treatment. So there's no advantage particularly. It's certainly marketed as such. It's probably marketed quite heavily as such. But the reality is that if you're getting treatment with a VMAT, with a rotational arc therapy treatment on the conventional linear accelerator, you're getting exactly the same treatment.